Honorable dignitaries, esteemed faculty, and dear delegates, a very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on the behalf of the entire team at MCure. We at MCure are proud to present Cardio Colloquium, our highly acknowledged scientific program dedicated to exploring the multifaceted landscape of cardiology. This program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance the lives of those affected with the cardiac diseases. I take this opportunity to extend a warm welcome to our respected moderator today, Dr. Dilip Kumar sir. Sir is Director, Cath Lab and Senior Interventional Cardiologist at Medica Super Speciality Hospital, Kolkata. He is complex coronary device and structural heart expert in Eastern India, Chief Academic Coordinator, Medica Institute of Cardiac Science. He holds University Topper Award in DM Cardiology from West Bengal University of Health Sciences 2007. He has many professional memberships to his credit. He is recipient of Healthcare Pioneers of the East 2020 Award by the Times Group. He is principal investigator in landmark clinical trials like IBIS, Presco, Tuxedo, Lively Watch, Evermind Stent, PCHF, and co-investigator in Global Desiccate Registry, Heart Failure Registry. Sir has numerous peer-reviewed publications in leading cardiology journals to his credit. He has also authored book chapters and yearbooks in cardiology. Thank you, sir, for joining today. Let me have privilege to introduce our expert panelists for today. We have Dr. Vikas Singh, sir, Senior Consultant and HOD at Cardiac Sciences Mediversal Multi Super Speciality Hospital, Patna. We have Dr. Soumik Chaudhary, sir, ICCU in charge and Clinical Lead, Department of Cardiology, Peerless Hospital, Kolkata. And we have Dr. Ram Sagar Roy, sir, Chief Consultant Cardiologist at Paras HMRI Hospital, Patna. And finally, I would like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me brief you all on the meeting agenda for today. We'll kickstart the program with the keynote session on optimal selection of RAS inhibitor in post-MI patient by Dr. Dilip Kumar, sir. The meeting will proceed further with the panel discussion, where our moderator will drive the discussion. In the end, we'll take a few questions from audience. I request audience to put their questions in the comment box, and this will be followed later by concluding remarks by Dr. Dilip Kumar, sir. So now I would like to invite Dr. Dilip Kumar, sir, to deliver keynote session for today. Over to you, sir.
Thank you. Thank you, Dr. Rishikesh. And it's wonderful to have a good panel with us. And as a topic extremely, important in today's perspective, where a lot of influence and a lot of things which are scientific needs to be discussed more often, and the correct clinical practice needs to be established. So I hope my slides are visible to everyone now.
Yes, sir.
Yeah.
We can see.
So this is a very pertinent topic, optimal selection of RAS inhibition in post-myocardial infarction patients. So we have got clarity in now choosing the drugs, in chronic heart failure, those who are decompensated heart failure, those who are acute myocardial infarction, ACS. And let's have an overview of what all evidence we do have in this perspective in ACS, acute myocardial infarction, and the RAS inhibition. So we have choices like ARBs, ARNIs, ACE inhibitors, which is, for so many decades, they have proven their worth. And we also need to have an idea about what the current guidelines suggest and what are the evidence on which they are based, upon. So when we talk about, angiotensin, inhibition, RAS inhibition, we have ACE inhibitors for a long time. And then we need to have kind of alternatives which we feel that this could be better, which could have lesser cough, which can have better compliance, better blood pressure reduction, and from there the concept of ARBs and came, and they in hypertension they are well placed, but in acute myocardial infarction setup, heart failure setup, it needed to be established on ground with drugs, with studies, and we have two landmark trials depending on that, Optimal and Valiant. And Optimal was done with losartan 50 mg once daily versus captopril 50 mg thrice daily, and then there was a Valiant trial with
recording in progress.
Valiant trial with valsartan That was a huge, large trial with 14,000 patients. And what the results were, the optimal did not show any benefit. There was no significant difference in total mortality, but the trend was in favor of captopril. And with Valiant and with the valsartan and Valiant, there was a large trial with 14,000 patients. Valsartan also proved to be as effective as captopril, but there was no edge or additional benefit. So this was the optimal trial, and the primary endpoints you can see here as compared to losartan, as compared to captopril, there was not much of difference with a relative risk of 1.13 and confidence interval, going towards line of unity. So you can see here the secondary endpoints, the tertiary endpoints. There was no significant difference at all. So we did not have, what we thought optimal could give us, because by that time, losartan was more or less established in hypertension treatment. There was a life trial, and a lot of buzz was there about losartan. And we were, postgraduate students that time, and we were talking a lot about losartan, I think in 2002, 2003. But this trial did not give us the same expected result, and ACE inhibitors were still preferred. Further, Valiant trial was tried with valsartan, and this was an acute myocardial infarction, 14,000 patients. And we can see here the curves of Kaplan-Meier curves, not diverging at all. And although it was a little bit in favor of valsartan, but there was no significant difference. And the more or less the ARBs and ACE inhibitors rivalry in acute myocardial infarction was settled with that. And there was no proven kind of benefit of ARBs on ACE inhibition. And we have loads of trials with the ACE inhibitors in myocardial infarction. So, so the guidelines, still sticking with the ACE inhibitors, because the evidence which is there is really overwhelming. And I will be going through those evidence in my last slides. The ARNI, the paradigm heart failure trial came into 2012, and from there everything started changing, and people thought that we have got a correct way of neutralizing the RAS, and by with NEPAS inhibition we are going to get the better results, and this was proven in chronic heart failure, and this was also evaluated in Paradise MI trial to look for whether ARNI gives us the same benefit in acute myocardial infarction or not. And this was the trial of the study inclusion criteria of the study is worth discussing here. They took very sick patients. So those patients were less than 40% ejection fraction, or with pulmonary congestion, those who are in the same day of admission till 7 days of discharge, till 7 days, they needed to have additional risk enhancer, and that was in form of either age more than 70 years, GFR of less than 60, or diabetes, prior MI, atrial fibrillation, LV ejection fraction less than 30%, KLIP class more than 3, STEMI without reperfusion. So they were really, really sick patients. The only exclusion criteria was eGFR less than 30, prior heart failure, and obviously those patients in frank cardiogenic shock. So besides these cardiogenic shock and eGFR less than 30, these patients had real bad substrate. And they were compared ramipril with ARNI, and the results were really, once again, were quite surprising. The ACE inhibitor still proven to be standing tall, and you can see here CV death, first heart failure hospitalization or outpatient heart failure hospitalization. There was not much of difference with P of 0.17. The CV death, heart failure hospitalization, outpatient heart failure. So there was a kind of 3.1 to 3.6 CV death from ARNI versus ramipril, heart failure hospitalization again 3.3, 3.8, and outpatient heart failure 0.7 versus 1.1. So not much of difference. And when it comes to side effects, there were more hypotension in ARNI group as compared to ramipril group, and as expected, cough was more common in ramipril as compared to ARNI. But that was not much of clinically relevant. And the consensus was the sacubitril valsartan did not result in a significantly lower rate of CV death, heart failure hospitalization, or outpatient heart failure requiring treatment. And the pre-specified observations of reductions in both the investigative reports of the primary composite as well as in the total adjudicated events support incremental clinical benefits of sacubitril valsartan, and safety-wise both were equal. But the desired and what was expected, that ARNI will be proven in acute MI also beneficial, and it can replace RAS, ACE inhibitors. So there was also a trial with ARNI in stage 4 heart failure, where this was a negative trial, and these two trials clearly established that no, ACE inhibitors still go strong, and we have pounding continuing evidence on ACE inhibitors. Those patients who were treated with ACE inhibitors in MI, they have given more perspective and hard evidence that ACE inhibitors can't be replaced here. So these were the reactions from worldwide with on Paradise MI. How the sacubitril valsartan did not outperform ACE inhibitors after MI. The American College of Cardiology, made their headlines. But the Bedscape, it was sacubitril valsartan can't beat ramipril in patients with acute MI. So everywhere from the medical to social platform, this was discussed, and ACE inhibitors was still the drug which we can depend on when it comes to acute myocardial infarction. So let's discuss the evidence which is generated with ACE inhibitors. So we have discussed about ARBs with ACE inhibitors, ARNI with ACE inhibitors, but how about ACE inhibitors? How they have proven their worth, and what's there in store with ACE inhibitors evidence? So let's look at that. So we have got 3 very strong trials, and like SAVE, AIR, and TRACE, and all these patients were in we are having low ejection fraction or a significant valve motion abnormality or a clinical heart failure. And also we have broad, a large database from consensus to GC3 and ICS4. So I will be going through these slides, and these are really eye openers. Those who feel that no, ACE inhibitors should be replaced with ARBs or ARNIs, because there was little better trend with ARNI. But we need to have ARNI results, proving their worth, particularly in acute MI situation. But these situations can't be reproduced again. So these were days where there was no primary angioplasty. Availability of primary angioplasty was challenged. It was those were there streptokinase, not even tenecteplase or alteplase. So these trials were done on those days, and the continued results for 1.5 to 2 decades really is worthwhile to visit. So this was a SAVE trial in 1992. It was published. It was a survival and ventricular enlargement study. This was a randomized, double-blind, placebo-controlled, multi-center trial. Those patients with MI with LV ejection fraction less than 40%, between 3 to 16 days of the event, and all these patients underwent MUGA baseline, those who needed, and at 36 months. And captopril was given 50 milligram thrice daily as maximum dose. Follow-up was 24 to 60 months. The results showed that captopril reduced 19% mortality and 25% in recurrent myocardial infarction. The cavity dilatation was reduced, and these benefits occurred equally in patients who received lysis plus beta blockers and in those who did not. So that's what I was alluding to. These benefits with ACE inhibitors, where even with those patients who did not receive lysis and beta blockers, and there lies the subset of patients which we can't reproduce. And when we go through the same efforts and exercise in having ARNI in the same block as ACE inhibitors, these are very difficult situations, and the evidence which is there with ACE inhibitors on long term is really remarkable. Coming to TRACE trial, this is Trendopril cardiac evaluation study. This was a randomized, double-blind, placebo-controlled, multi-center trial. Again, those patients with myocardial infarction with residual valve motion abnormality were randomized between 3 to 7 days, follow up for 24 to 50 months. It again showed for 25% reduction in mortality, 15% reduction in recurrent MI, 20% reduction in sudden cardiac death. So TRACE also gave us the same kind of benefit which we saw in the SAVE trial. And these were the evidence post-MI from large population, 58,000 patients in ICS-4. This international study on those patients were infarct survivors. Captopril was effective in reducing 5-week mortality. GISC3, again, 1994. Those were days where, thrombolysis were only available. And 18,000 patients, listompril again stood tall with, started within 24 hours MI, effective in mortality reduction, severe left ventricular dysfunction reduction. And CCS1, again 14,000 patients, and interval myocardial infarction of captopril treated group was found to have lower mortality. So these three large population studies and the trials designs were also very effective, and they have shown very significant benefit with captopril, lesinopril, and ACE inhibitors. And this was again a very important study, AIR trial, and we have long-term data with AIR, which I'm going to discuss. So this was a randomized double-blind placebo-controlled trial, acute MI 3 to 10 days. Ramipril was the drug used. That's become more important for all of us because at this moment we have only Ramipril, which is in market, and the AIR trial becomes more important for all of us. So let's discuss this in a little more kind of focused way. So AIR trial showed us, gave a benefit of 27% reduction in mortality, 19% reduction in rate of myocardial infarction, and a stroke at 6 months. So we can see here there was a huge 27% reduction at 6 months. And this is the AIR extension study. 603 patients who were given ACE inhibitors, Ramipril, in the AIR study. They were followed up in long term, and the benefits which are given was we got a benefit of 36% reduction this time, and beneficial effect of Ramipril started early after MI with heart failure are sustained over 3 to 5 years despite discontinuation of medication at 1 year. So those patients who had stopped the Ramipril after 1 year of study drug, in the study they were taking at 1 year, even those patients got benefit. There was a relative risk reduction of 36%. So what was concluded is treatment of 9 patients with Ramipril for an average of 1 year will result in 1 additional survivor to 5 years. So this is a statistical analysis, how they looked at this data, but this looks very convincing that those patients, this kind of something like legacy effect is happening here, like in what we have seen in UKPDS trial, where there was a legacy effect of the oral hypoglycemic agents. Here also we can see here, if we start Ramipril, if the patient's in acute myocardial infarction, the remodeling is prevented, and after 1 year, even if you leave this, it has done its job, and you get a better long-term outcome. So let's look at even longer follow-up. Ramipril's long-term survival benefit in acute MI patients complicated with heart failure, AIR survival, and this is 2021 published. This was at 29.6 years after randomization to assess the long-term magnitude of impact on length of survival. So this is possible only when you have everything linked with government data and government, their database. So in UK, where it was done, everything was in the government database. Those patients who were given this trial drug, what happened to those, how many patients died, how many patients were still surviving, what happened to those, what happened to their next medical history. So everything was available, and that's where the entire long-term insights we are coming to know and gaining our experience. So this AIR study follow-up 0 to 29.6 years. I don't feel many more studies have seen this kind of long-term follow-up. A few like UKPDS, ASCOT-B, PLA, and then some hypertension landmark trials, they still follow their patients, like HOPE trial. But and an AIR trial also fits in those kind of landmark trials. And uh, what was seen was median survival time was 8.3 years versus 9.6 years in ramipril group. So there was extension of life by 15 months, more or less 14.5 months. Survival curves cross at 14 years from the time of randomization. Life expectancy was greatest at about 15 years, and life expectancy was improved with ramipril across all the comorbidity groups. So very, very important insights through this long-term follow-up data of AIR. And look at this very, very useful slide and very important slide. We can have a discussion on this slide. What is the life expectancy difference? So life expectancy difference with ramipril, without ramipril, especially in patients with diabetes, it was huge. It was 32 months versus 5 months. It is the median. How much is the difference? So those patients with diabetes were far better placed with ramipril. Previous MI 20 versus 4.9, hypertension 16.6. So more sicker the patients were, more side kind of comorbidity was there. There was a more benefit with uh, ramipril. That's what we get an idea. So long-term survival benefit ramipril in patients with acute myocardial infarction complicated by all these hypertension, age, diabetes, history of angina, previous heart failure, and we can see here the difference is really huge. So there was substantial survival gains with ramipril treatment for 15 years beyond the blinded treatment allocation. And overall, with this statistical analysis, we can conclude that for every day a patient received ramipril, on average, his or her life was extended by a further day. So we can see how big is the benefit. And the relative risk of survival for patients with diabetes was increased by 54%. And particularly if the patient was diabetic, this benefit was enhanced by 54%. So a diabetic with a heart failure patient, with a hypertension, with a elderly patients, if you give this ramipril, you can imagine how much benefit they are going to get. Then those patients who don't have these kind of risk factors, but still less than 40% ejection fraction, the classical patient, but with classical with more comorbid patients, they get the maximum benefits. So patients with diabetes, previous MI, previous heart failure, hypertension, angina, each benefited on average from ACE inhibition. Combining, you can appreciate and you can imagine the benefit with the patient can have. Treatment with ramipril for about 1 year when started early post AMI in patients with heart failure results in a survival benefit which is sustained over many years and offers an average extension of life for initial 1 year. So this was this I am reading it out again because these things are really remarkable. And if we don't go through these analysis, we were totally blind and oblivion about how ACE inhibitors are there making beating every other new molecules which we feel that RAS inhibition this way can be beneficial. So when it comes to all these trials, all these discussions which we had, the concluding remark which can be made by which can be very clearly made is treatment with ramipril for 1 year can give you an additional year of life. So what do the current guidelines suggest? We have got huge evidence, and with this huge evidence, with the studies which we discussed, basically they were the core analysis, core kind of data on which the guidelines were made. And that is where the timeline of drugs which we give in acute myocardial infarction are endorsed in guidelines and are founded on and which is used in clinical practice as well. So once a patient comes with acute myocardial infarction, definitely we thrombolize or we do the primary PCI, but within 24 hours, ACE inhibitors should preferably be started in these patients, provided the blood pressure is all right, which we'll be discussing, taking insights from our panelists. When do they start their, RAS blockers in acute myocardial infarction? And for beta blockers, let's go slow. For 24 hours, let's look at hemodynamics. Then you can start beta blockers. After 24 hours, try to avoid beta blockers in the early hours. And early introduction of aldosterone within 7 days of index myocardial infarction is also recommended. And we have to titrate the dose of all these in follow-up to a desired level. So this is how we start the drug in acute myocardial infarction and titrate. And Jack acknowledges AIR with ramipril, 1993 Lancet publication, and we still have 29.6 years follow-up of some of the patients, and it has given us huge insight. So when we as a doctor, we talk about landmark trial in cardiology. These are some of the trials like HOPE, some of trials like UKPDS for drugs like diabetes, and the same way we ASCOT in blood pressure. Same way we get AIR trial for ACE inhibitors in myocardial infarction. And then can appreciate here the overwhelming evidence with ACE inhibitors, SAVE, AIR trace, and so much of GC3, ICS4 large data which is available with us. And as compared to ARBs, we have two only optimal variant, no single arm trial with because by the time they came, the patients were already on multiple drugs which were available, and they had only to prevent their worth against ACE inhibitors. So 2020 guidelines, ESC clearly shows ACE inhibitors are recommended in patients with heart failure with reduced ejection fraction, post-myocardial infarction, especially these the patients with diabetes or CKD unless contraindicated in order to reduce all cause and cardiovascular mortality. Class 1A indication. Beta blockers are also a class 1 indication, so as the MRAs, but their timing can be different as what we have seen and discussed. This is 2025 guidelines released February 2025. ACE inhibitors still maintains its lead position in acute myocardial infarction, ACS with ejection fraction less than 40%. And you can see, especially those who are hypertensive, diabetes, ACE inhibitors should be given as class 1 indicated drug. Only if the patient is intolerant, ARB should be or considered, otherwise not. And the same thing goes with beta blockers and aldosterone antagonist as it was in 2022. So with this, let me go to panel discussion, and we can start and initiate the insights from our esteemed panel. And first question goes to Dr. Vikas. So all these trials which we discussed, evidence, guidelines, let's talk about the practical aspects and how we do a practice. So in the post-myocardial infarction patient, post-revascularization, at what systolic blood pressure do you initiate ACE inhibitor therapy, and what is the starting dose do you recommend, and how do you up titrate the dose? So can we Dr. Vikas?
Sir, I'm here, sir.
Yeah. So can you take this question?
Sure, sir. Sure.
Yeah.
So, very good evening, everyone, and thank you, Dilip sir, for bringing out some very good aspects about an already proven drug, a very important drug in our armamentarium, particularly when we are dealing with ACS and post-ACS scenario, ramipril. So, as a general rule, I prefer starting my patients on an AC inhibitor with a systolic blood pressure of 100 or more. But having said that, that is not always the rule. There are patients where your blood pressure is always hovering around 9500. So that is not always a contraindication. The only thing to look out for these patients is to be more cautious, starting with a little dose of ACE inhibitors maybe. For all my patients, otherwise, whose blood pressure is around 100, I would start with a very low dose of ACE inhibitor, maybe 1.25 of ramipril, and then go on building the dose as the patient presents to me back for follow-up, and the tolerability part, particularly in terms of hyperkalemia and the blood pressures and postural hypotension is not there. So I start my patients on 1.25, gradually go on building the dose till the target dose is reached, which is possible in most of my patients. But then there are patients where you have to be satisfied with the lowest dose that they can tolerate. 100 should not always be the barrier. You should be taking into account each and every patient on an individual basis. And there are patients who have been tolerating this drug very well, even at a systolic blood pressure lower than that. but then you need to be very careful in looking for the side effects, particularly in terms of postural hypotension.
So do you up titrate in hospital itself? So day one, you have started Ramipril 1.25, you see a blood pressure of 110. And when you are discharging the patient, maybe at day 3 or day 4, after a primary or stabilizing the patient after thrombolysis, at day 3, do you up titrate to 2.5 or let the patient go home in discharge after the first follow-up of 7 days or 14 days, you take it to 2.55? So how do you do?
If I'm very comfortable with the blood pressure, the BP range is very comfortable for me, I at least bring it to 2.5 milligram before discharge. But otherwise, if that is hovering around 100, 110, I prefer to up titrate the dose at the time of first follow-up, which is usually after a week of the time from the discharge.
Yeah, and many times we see that patients, some of the physicians, they have got idea that these are life-saving drugs, so let's give a good amount of SN inhibitors and beta blockers. They will save the patient, and we get the patient in shock. And then the emergency doctor says, "Sir, doctor, patient has come, is in cardiogenic shock." So if the patient has transferred from some nursing home, small nursing home, where they went in and they have given 5 milligram of Ramipril, 25, 50 milligram of beta blocker, aspirin, statin. And then by the time they come to us after 6-8 hours, their heart, blood pressure comes to 85, 86, and our emergency doctor pronounced that this is in cardiogenic shock and you have to do emergency primary. But we see the patient ejection fraction is 38, 40, not very bad, and his heart rate is all right. He's conscious oriented. Uh, so we also we need to emphasize whenever we talk to general physicians that start with the lowest possible dose. And if you don't have further treatment, good ICU, you don't give 5 milligram of large doses of SN betas or beta blockers. Otherwise, these patients sometimes get hypotension and they can be detrimental also.
So that is a very valid point that you have raised, Dilip sir, because a very good drug may fall into disrepute only because that is not being properly used. So we have seen that with many of the molecules. Prasugrel, when it came, we saw patients receiving any doses of Prasugrel, 2 tablets, 4 tablets, 8 tablets, anyone was receiving any dose, irrespective of the body weight and the bleeding risks and everything. So we need to understand this is a wonderful molecule, no molecule like a RAS inhibitor, any particular an AC inhibitor in your post-ACS patient, but that has to be judiciously utilized in the way it is supposed to be used. And always start with a low dose that will also make your patient tolerate and go build up the higher doses in times to come.
Right. So let's move on to Dr. Ram Sagar, his insights on a very strange kind of question, which we practically find many times. Suppose a patient who is already on ARB for hypertension, he gets an heart attack, myocardial infarction. Now he is admitted under you. So are you going to switch it over to ACE inhibitor, or are you going to continue with ARB? So what's your take and how do you practice in these patients?
Good evening, sir and dear friends. First of all, I'll present already on antihypertensive drug like ARB. But first of all, we would like to see whether the patient is suffering from which type of myocardial infarction, whether it is inferior valve MI or lateral valve MI or extensive anterior valve MI. So first of all, I want to stop the ARB because the efficacy is very high. The efficacy is very high, and it can, if the patient is suffering from extensive interval MI, ejection fraction will be very low, near to 30-35, then chances of going into the hypotension and cardiogenic shock is very high. And initial first days, there is chances of arrhythmia high. There different type of VT, VF, and block maybe chances of block may be high. So first of all, I will want to stop the ARB. And later on, after once the patient is stabilized, just within 24 to 48 hours, they will like to assess their blood pressure, whether blood pressure is near to 100, and then I will want to switch on the AC inhibitor. And the dose will be according to blood pressure. It will be started from 1.25, and gradually it will be titrated. So this is the myself.
Yeah, looks very scientific. Your approach is very scientific, and you're very right. The patient comes with myocardial infarction. First thing you do is stopping the drug. Whether you see the blood pressure of the patient is still there, more than 100 and 110 next day, and then you can restart with ACE inhibitor in low dose. that looks more a rational approach. And I think your idea and your practice is all what we do as well at our center and everywhere people are doing. So now let me go to Dr. Somik and get an idea about his his kind of thoughts on and his practice on how early does he think that ARNI can be initiated in a patient post-myocardial infarction.
Good
Dr.
evening,
Dilip
sir.
sir, your slides
Somik,
are
yeah.
not visible. Question slides.
Somik, you want to see the slide?
No, sir, that's perfectly fine, sir. No problem.
Yeah.
Good evening, sir. Sir, am I audible, visible?
Yeah, very well.
Yes, sir. Yeah, that's actually a very good question, sir. I mean, how early can we start ARNI? And in fact, a lot of it, I think you've discussed already. Theoretically, sir, at any point where we are thinking of starting an AC inhibitor, we can start ARNI. If, as in, theoretically we can. But practically, it's not something that I do, and it's not something that's routinely also recommended. Initial period, in fact, if you look at the transition data, they looked at ARNI initially unless there is a stoppage of patients having inotrope support or patient is on a escalating dose of injectable diuretics. These are anyway contraindications for ARNI per se. But ARNI, if you look at the Paradise MI data, sir, ARNI theoretically did not show any, statistically did not show much significant improvement over amipril in the context of outcome improvements, whether it was improvement in the mortality or heart hospitalizations. We have much better data that's available with AC inhibitors. And as of now, sir, I would definitely look at starting an AC inhibitor in the initial period. Now, the question of if at all will I shift to ARNI, and if yes, then when? If the patient, I would usually wait up till at least 6 weeks. Some people agree with 3 months, but at least I say 6 weeks, allow the myocardium to the stunned or the hibernating myocardium to improve. And if after that also EF remains consistently less than 40, and there is maybe patient diabetic or has a CKD, early CKD, or patient has clinical heart failure still that persists, in those contexts, I would probably be thinking of shifting over to an ARNI, sir. But right in the beginning, no. And if the patient's EF has improved significantly and a patient is not in failure, then maybe I might not, sir, shift over to ARNI in the first place.
So there is a very, very valid point you made. ACE inhibitors, we have evidence, and we need to start with ACE inhibitors in post-myocardial infarction. But what happens to these patients over a period of time? And these landmark trials, 1 year it was given, and many patients stopped the drug because 1 year it was given, and then the sequelae of what all has happened, remodeling, reverse remodeling, what has happened, and how the patient behaved after that. There was also they were followed up. But usual scenario is if you start these drugs, you treat these patients, many patients had ejection fraction, which was initially 30, 35, it comes to 45, 50. And these patients, you can well go ahead with, if there is no clinical heart failure, you can, continue with ACE inhibitor.
Exactly. That's what I'm saying, sir. Unless the patient consistently remains low, we can continue the ACE inhibitor in these patients.
And if these patients heart failure remains there less than 35% and decompensates again in chronic heart failure, then there is always a good and evidence in favor of ARNI, and we can go ahead with ARNI in those patients.
Absolutely, sir.
So again, I think, so Vikas, those patients with less than 40% but no clinical heart failure, do you still feel you will go ahead with ACE inhibitors in these patients post-myocardial infarction?
Certainly, yes, sir. Certainly, yes. So there has to be no confusion over this. Revascularization, once done, has to be followed up with the guideline-directed medical therapy, because these are taking care of the long-term effects, the negative remodeling part that is occurring in the heart. So that has to be done in the same way that is done for a patient who has for some reason not received any form of revascularization. So revascularization or no revascularization, if ejection fraction is there less than 40%, even if there are no signs of heart failure, the patient has to receive, and all my patients do receive an ACE inhibitor for that.
To prevent the remodeling, you have to give this drug, irrespective of heart failure. That message has to be very loud and clear to everyone. And so I would like to have 3 focused answers from all of you, all 3 of my panel, about the preferred beta blocker and how do they start this drug, if which beta blocker they are using, and when they start beta blockers, and what about in combination of beta blocker and ACE inhibitor? How do they feel that is it going to work? We have combinations already in the market, but the doses are not very well available. So you start to 2.5 to oblique 12.5 or 1.25 or 12.5 is not available, or bisoprolol. So the focused questions to all of you: which beta blocker you use, when to use, and combination of ACE plus beta blocker in post-MI. Because you can start.
Sir, so I generally use a short-acting beta blocker. For me, metoprolol tartrate is what we use beta lock in low doses to begin with, just to see the tolerability part. And this is more so in patients whose, again, parameters and the hemodynamics are towards a more careful approach, I would say. The BP is on the lower side. So there, I prefer using the short-acting beta blocker, metoprolol tartrate. Once the patient is tolerating before discharge, I usually shift to the succinate, metoprolol succinate part. And yes, a combination of these two should be used because they both are taking care of absolutely different pathways which are meant to give benefits to these patients in terms of blocking sympathetic as well as the RAS inhibition part.
Dr. Ramsagar, which beta blocker you use post-myocardial infarction?
Sir, I am very much agree with Dr. Vikas, because the tartrate has we have provided of the option to titrate and stop anytime when we want. Whether a patient start to sink or any complication occurs, we can easily wean off the molecule. So I agree with Dr. Vikas, and I think after 2 weeks we should switch on succinate, long acting or any other.
Soumik, you also feel the same?
Yes, sir.
Not absolutely. So I am more of a bisoprolol person, sir.
Okay.
I prefer, because I have the titrability of bisoprolol and the potency, but I think dose for dose, the potency of bisoprolol is probably the best beta blocking action without significant antihypertensive action. So even in somewhat, I would say, very borderline BPs, 100, 110s, and I'm having tachycardia, post-MI patient, intercepted MI. These are type of patients I would want to give a beta blocker early, and bisoprolol is actually my choice, sir.
So there's a lot of heterogeneity and variation in practice, clinical practice, and evidence-wise also there is no clear consensus that which beta blocker should be used. But I agree with Vikas and Ramsagar that mostly the cardiologists, they fall back on metoprolol in myocardial infarction situation. But in chronic heart failure, majority of us cardiologists are shifting to bisoprolol. So this is the trend which we have seen, and both ways we are okay. So bisoprolol 1.25 we can start well, or metoprolol short acting, as Vikas and Dr. Ramsagar told, to just have an idea that if the patient's heart rate is going down, the effect will go away very early and you will be saved. So safety wise, that could be a good idea. So a very small dose combination with ACE inhibitor and beta blocker, maybe a metoprolol, better choice. And bisoprolol, obviously most of the patients will be shifted to bisoprolol. Chronic heart failure, this is the drug which is getting more and more used in India as well. Previously, I think in a decade back, it was all metoprolol only. Coming to last couple of questions, and then we'll go for audience questions from audience. This is to Dr. Ramsagar about NT-proBNP. If you do it and then decide as marker for ARNI over Ramipril in follow-up, or you just go for clinical criteria decompensation, as what Dr. Soumik told. So do you follow these patients with NT-proBNP acute MI after 6 months and NT-proBNP is higher than shift to ARNI, or you just watch these patients if clinically, and if they decompensate, do you start on ARNI?
Sir, as the NT-proBNP test is slightly costlier for the people of our native lands, and so I hesitate to use NT-proBNP as a marker of prognostic marker in case of CHF. So I mostly stick on the clinical guideline, hemodynamic symptom, well-being, as well as the well-being, sign of well-being, vitals. So I hesitate to use NT-proBNP. I mostly stick on clinical guideline for using the ARNI.
Great. So you do mostly watch these patients clinically, and pro-BNP, if the patient is symptomatic, there is no point going for pro-BNP. That looks a very rational approach. Uh, and if you are meticulous enough, you can go ahead with pro-BNP also, but clinical follow-up makes sense. And finally, final question to Dr. Soumik Chaudhary before we take the last expert panel comment on one question for all of you. This is directed to Soumik only.
Yes,
Will you
sir.
start ACE inhibitor in all the patients with ACS, whether revascularization is planned or not, or you are going to do, or you have done it or not? So revascularization status and ACE inhibitors in ACS.
Sir, to be very honest, it's not really the revascularization status that really makes the difference for ACS. It's a remodeling. So whether the revascularization is taking place or not taking place, what I will be really looking at is obviously the ejection fraction. Is there an improvement? There are patients who do have sometimes, not always, sometimes have improvements even on medical therapy and who have not undergone a significant revascularization. I will obviously be looking at if there's heart failure on. Well, that will decide a lot of part whether I'm calling it a chronic heart failure or acute heart failure. Anthroceptal MIs probably I will be more in tune in giving ACE inhibitor for a longer period or a RAS inhibitor. And if there are comorbidities like diabetes, if there's a CKD, hypertensive, where I can actually even give the ACE inhibitor from the hypertension point of view as, I mean, it's a workaround, but I can use that as my reasoning for giving it.
Correct.
Now, if the patient doesn't have any of these, non-diabetic, EF's perfectly fine, there's no heart failure, no comorbidities, then even if the patient is revascularized, I may not give it. Even if the patient is not revascularized, I still may not give it. So I would be revascularization is not my
More of
primary
ejection
concern.
fraction and
Absolutely. And diabetes, ejection fraction, hypertension, these kind of things, heart failure. These are things I'll be looking at.
So final question to all of you, all three of you, is ARNI 200 milligram twice daily versus Ramipril 5 milligram or 10 milligram. So how many patients you go up to 200 milligram twice daily of ARNI versus 10 milligram of Ramipril? So up titrating the drug to 10 milligram is very easy. And 200 milligram BD, which has been shown in paradigm heart failure trial or other trials, landmark trials, ARNI, which we, I think, go in only 20-30% of our cases. 70%
Maximum,
of
sir,
cases are 100
20%, yes, sir.
milligram. So what's your take on that? And you feel that these practice defies the clinical kind of mandate which is there and scientific evidence which is there, and by if we are going with this practice, Ramipril 10 milligram can be a better choice.
I agree, sir, because, yeah, sorry, sir, this is
I
Soumik.
mean, please go ahead. Please go ahead.
Yeah, no, I agree with sir. I think 20% also, sir, is being a very, very, I would say, lovely and wishful statement. Probably it's 10 to 20%, I would say, because honestly speaking, going up to 200 mg/d doesn't really happen. So because these patients are mostly already having a low EF. The BP really doesn't go up much. There's an MRA in there, there's a beta blocker in there. Most of my patients are on 100 BD or 50 BD. I mean, I'll be honest on that. A lot of my patients are on 50 BD as well. Quite a few are on 100 BD, very few are on 200 BD. But I think probably a Ramipril 5 BD I could reach earlier than I could reach a ARNI 200 BD in these kind of patients. So I agree. I think.
That's a very practical difference, sir, in what we are getting from the guidelines and what we are getting to use in clinical practice, because that target of 200 milligram BD is definitely not achieved in vast majority of our patients. So that is absolutely true. And then we have to look into everything in that perspective, that what benefit are we going to give with that lower dose of ARNIs than what has been tested in the guidelines. Or in the, for that matter, in the trials, yes.
Yeah. Dr. Ramsagar, you also agree with?
Yes, sir. Yes, sir. I agree with you, sir.
So the points are well settled. ACE inhibitors has to be there right from beginning day one. It has to be start low, go slow kind of thing. And then once we are there, follow up. If the patient is clinically stable, heart function has gone up, you can continue with ACE inhibitors. If you see the clinically patient deteriorating, you can shift to ARNI in follow-ups. So this is how we go ahead, and obviously the dose which we are reaching up to becomes more easier in ACE inhibitors, and that makes a point in favor of ACE inhibitors once again. So with this, we can have 1 or 2 questions, and we have, I think we have reached our allotted time. And Dr. Rishikesh, up to you now.
Yeah, sir, there are just 2 questions in the chat box, sir. If you are
Please go
able
ahead.
to
Please
click
go
on
ahead.
the
Yeah.
chat.
So
Okay,
yeah,
I'll take it.
so
Yes.
let me read out those questions to our panel. Doctor,
Yes.
what is your drug of choice in high CV risk patients? Which on you prefer ACE inhibitors or ARBs? I think the answer is already given. ACE inhibitors are the #1 choice drugs. And if the patient is intolerant to ACE inhibitors, we can't give, then we shift to ARBs. As per Transcend trial, ARB shown no superiority of placebo. What is panel's opinion on it? So yeah, so there are so many trials, not Transcend, so many trials are there where the benefit of ACE inhibitors, which is very stark as compared to what we see with ARBs. And in some of the ARBs, even in myocardial infarction, some concerns have been raised. Like olmesartan, we have some hint that it can be counterproductive, as well. So better avoid ARB practice, especially in acute myocardial infarction. That message should go from our side. Great.
Thank you, sir. Thank you for the interesting panel discussion. We are nearly at the finish line, but before we conclude, let's express our gratitude to all those who made this scientific program possible. I would like to express my sincere gratitude to our esteemed moderator, Dr. Dilip Kumar sir, for delivering the excellent session and driving up the interesting panel discussion. I would also like to thank our expert panelists, Dr. Vikas Singh sir, Dr. Ram Sagar Roy sir, and Dr. Soumik Chaudhary sir, for sharing their knowledge and expertise with us today. I would also like to thank our esteemed audience for their time, continued love, and support for the Colloquium program. On behalf of MQR, I extend my heartfelt thanks to everyone from sales, marketing, and medical team at MQR who have contributed to this program's success. Thank you all once again for attending and encouraging us. Good night and good time ahead. Thank you.
Thank you.
Good night. Thank you, sir. Good night.
Thank you, sir.
Thank you. Good night.
Good night.